project is funded by SEIU 1991. It's a privilege for us to be a part of that. You know, they've got $106 million in the voluntary labor concessions. You know, they're bringing in this Sellers Dorsey firm to help with the revenue maximization piece. Labor as a very, very key stakeholder in this equation has really put their money where their mouth is and is vested in the success of Jackson moving forward. High level of cooperation and coordination with a variety of stakeholders. I talked about administration. You know, Jackson, the thing that I've been as impressed with anything to learn is the quality of the Jackson internal efforts that are going on in various domains. As a matter of fact, every time we would come up with something that we thought was innovative or creative, it would be like, hey, we've got a work team working on that. So we're happy to join into that, and we think that's a very positive dynamic here at Jackson. You know, we want to, and we have been working very cooperatively with PwC. Bill Llewellyn back there and I, we have several clients together actually that we have the opportunity to discuss, and so we are very vested in being cooperative, not only to avoid duplication, but as importantly to avoid confusion between our teams, the hospital, you guys as governance, etc. And we've become very integrated with the Operational Efficiency Task Force. Melita Keita, I don't know if this is here, has been just wonderfully receptive to our efforts, and we appreciate her. This is the task force, as a reminder, that was formed as part of the union concessions. I'm going to go through that because I know that you guys have had a very long day here. These are some of the KPIs that we are in conversations with, evaluating with Dr. Ta and Dr. Woosley and in the emergency department. So we're very pleased to have that involvement. But just I'm going to highlight a couple of these things. Compliance with evidence-based medicine guidelines. Interqual is a very important tool. It's a McKesson tool that really takes a lot of the variability out of servicing patients who have similar diagnosis and kind of symptoms. And it looks like that the ED has adopted those guidelines and is using them. I would acknowledge the ED. They've been on the electronic health record here since 2006, which is really, in the age of electronic health records, that's kind of an old timer. So that's very good. We track turnaround times. A lot of times, emergency departments, by the way, get beaten up for problems in the ED, but actually they're really institutional issues. You can't transfer someone out of an ED if you don't have a bed. You can't transfer someone out of an ED if you don't have a physician that is willing to accept that transfer. You can't transfer someone out of an ED if you're sitting there waiting for diagnostic imaging or for a consultant in the ED. So all of these different pieces need to be understood at really a granular level in order to make meaningful and sustainable progress. You don't just tell the ED you want a turnaround time of X, because in the business we call that kind of a lagging indicator, which really is the reflection of doing a lot of things well. So we try to identify and work with leading indicators that would help them actually move patients through versus beating them up for not doing so. So we're really focusing a lot on the turnaround times on a granular level to identify where barriers are. The left without being seen rate is such an important dynamic, not only financially, but really culturally. The RED is such an important part of this system, and patients who leave for one reason or another are going to tell a friend and another friend and another friend, and so that's really something that we want to help influence, and as I'll show you, it also has a very important financial implication. Bed assignment time, you'd be interested to know, and I'm not going to share the numbers right now, but of the total waiting time in the ED from admission to discharge, about 2/3 of it is waiting for a bed. So it's not waiting to be seen by a doctor, it's not waiting to be triaged, it's not any of those things, it's waiting to get a bed, and that could be for a number of factors, including the lack of availability of a physician or simply the lack of availability of a bed. So we will be working in establishing some benchmarks there. Patient, employee, physician satisfaction. Satisfaction is clearly the measurement of how we're doing, and right now we're not doing much in this area. We do participate in a patient satisfaction survey. Our population probably isn't very good at returning surveys and those kind of things, so we might be recommending a different mechanism to solicit their feedback. Decompression is really important, shifting lower acuity cases away from the ED to primary care. We're very supportive and encouraged and impressed by the work that's ongoing in the evaluation for the Federally Qualified Health Center. Obviously that's in the recommendation stages, so there's a lot of details to be worked out there. We think that's the right thing to do, not only financially, but that really is an opportunity to establish a medical home for these patients and stop the repeat visits on the chronic conditions like diabetes and asthma and arthritis. We acknowledge the ED, they have an express care capability, but we still see a fair amount of low acuity patients going